So, good evening. Today we'll be talking on assessment and management of increased intracranial pressure. I will be discussing this topic under the following headings. We'll introduce the topic, and then we'll see the key intracranial anatomy and physiology concepts. We'll talk about intracranial compliance and cerebral autoregulation. We'll also talk of dynamics of ICP and ICP waveforms. And we discuss about Monroe-Kellie Doctrine, then cerebral edema, and we discuss the etiology and diagnosis of elevated intracranial pressure, the symptoms, signs, the stages, herniation syndromes, and what are the investigations for raised ICP and monitoring of ICP. And then we'll have an algorithm for management of ICP control, head posturing, hyperventilation, osmolar therapy, sedation, seizure control, hypothermia, hemicraniectomy, barbiturates, and steroids, etc. Intracranial pressure is defined as the total pressure within the intracranial vault. Intracranial pressure results from the contributions from intracranial fluid compartments like brain tissue, more than 80% of the fluid, blood, and CSF. It is typically around 8 millimeters of mercury, and elevated ICP has been associated with poor outcomes. Above 40 millimeters of mercury ICP is catastrophic. The key physiology and anatomy concepts. The blood, CSF, and brain are stuffed inside the skull to create a mildly positive intracranial pressure. This is a function of volume and compliance of the semi-rigid cranial vault, in which the blood, CSF, and brain parenchyma are stuffed. These three components exist in a state of volume equilibrium such that a change in the volume of one component should be compensated by change in the volume of the other two. The second important point is that cerebral neurons are fully dependent on cerebral blood flow. There should be a constant supply of oxygen and glucose through blood to the neurons. And the demands are also, oxygen demand is about 3.5 ml per 100 grams per minute. And the stores last for only 10 seconds. Glucose utilization is about 5 milligrams per 100 grams per minute. It lasts for only 2 minutes. So the moment an artery is blocked, the stores will disappear within 2 minutes time for glucose and 10 seconds for oxygen. The main concept here is the cerebral perfusion pressure, and which is a pressure difference across arteriovenous beds in the brain, and this should be optimal for cerebral blood flow to occur. So cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Normally, the CPP is about 80 millimeters of mercury, and if it is less than 50 millimeters of mercury, then ischemia and reduced electrical activity sets in. So this is a concept which all students should remember. The fact is that cerebrovascular resistance is kept constant over a wide range of cerebral perfusion pressure via constriction and dilatation of the microvascular networks. These are the buffer systems for autoregulation. Autoregulation is effective between a mean systolic pressure of 60 and 150 millimeters of mercury. And beyond these limits of mean arterial pressure, the ICP raise will be very steep. You can see in one of the graphs now. So let us recapitulate that the normal cerebral blood flow is equal to cerebral perfusion pressure by cerebrovascular resistance. And it is usually about 50 ml per 100 grams per minute. And if it falls below 18 to 20 ml per 100 grams per minute, then physiological electrical function of the cells begins to fall. So The autoregulation maintains a constant blood flow between MAP of 50 to 150 minutes of mercury. So what is intracranial compliance and cerebral autoregulation? The metabolic requirements as well as cardiac and respiratory variations modulate the cerebral blood flow, providing compliance. Intracranial compliance is dependent on autoregulation. It is essentially a relationship between intracranial pressure and blood volume, and the curve is mono-exponential. At lower pressures, that is pressure by volume, that is the change in the pressure by change of volume, there is elastance ratio is small. The volume expansion due to a mass, if it is below 30 centimeters square, compensation is achieved by displacement of CSF from the spinal to cranial compartments and extrusion of venous blood from the cranium. If the intracranial volume increases beyond 30 centimeters square, decompensation sets in. That is the limit of the volume before the decompression sets in. Beyond that 30 centimeters increase in volume, the compensatory mechanisms get exhausted and there will be a sustained elevation of ICP and brain herniation and coning can take place. So the slope of the curve is determined by which component or compartment is expanding. CSF and blood are poorly compressible, so the slope is very steeper. Brain is compressible, so the curve will be less steep. So there is a difference between these two compartments, CSF and blood. They are poorly compressible, whereas the brain is compressible, so the curve will be less steep. Normal cerebral perfusion pressure, which is about 50 to 150 millimeters of mercury, is maintained through autoregulation, and changes in systemic blood pressure do not affect the cerebral perfusion pressure routinely. So whatever happens in the peripheral blood pressure usually does not affect the cerebral perfusion pressure. Because cerebral perfusion pressure is mean arterial pressure minus intracranial pressure, as systemic blood pressure increases, the cerebral perfusion pressure should increase, but due to effective autoregulation, the arterioles inside the brain dilate to lower the cerebral perfusion pressure. And when the systemic hypotension occurs, to raise it, the cerebral perfusion pressure arterioles constrict. So beyond these limits, autoregulation fails as the arterioles lose the ability to dilate and constrict. And then the cerebral perfusion pressure is determined by the blood pressure alone. So you can see the diagram. If the arterial blood pressure is the vasodilatory cascade, spontaneous, hypovolemic, cardiogenic, pharmacological. If there is a drop in the systolic blood pressure, the cerebral perfusion pressure also drops, and there is increase in vasodilatation and increase cerebral volume, increase ICP, edema, and CSF. This is a cascade that goes on like this. Similarly, you have a vasoconstriction cascade when the increase in this blood pressure. And so what happens if there is a increase in the blood pressure? The cerebral perfusion pressure also increases. You will have vasoconstriction, decrease cerebral volume, decrease ICP, and edema and CSF removal happens. So that the compensatory mechanisms are working properly. The hemodynamic and hydrodynamic state of the craniospinal system is a function of cerebral blood flow, intracranial compliance, and intracranial pressure. The cranial biomechanical state changes with normal activities. That is, change in body posture, aging, head trauma, and disease states like acute ischemic stroke, ICH, hydrocephalus, and Arnold-Chiari malformation, etc. The pressure volume curve. Intracranial compliance curves demonstrating the relation between intracranial volume and the pressure changes and the compensatory mechanisms are seen here. In patients with normal baseline brain volume and patients with baseline atrophy, because of advanced age or chronic illness, there is a difference. So you can see the change in the pressure. This is the high compliance and normal baseline volume. In elderly, because of atrophy, this is a low compliance state, and cerebral edema development will take place slowly in this case, whereas here it takes very fast. So this is the cerebral autoregulation capacity. The cerebral blood flow, which is in ml per 100 grams per minute. And here the cerebral perfusion pressure, which is millimeters of mercury. So they are the points here. 50 is the one point and 150 is the other point. So between these two, cerebral autoregulation keeps the cerebral perfusion pressure constant. And when it falls below, it becomes hyperperfusion, and it goes above. If a hyperperfusion, the hyperemia and edema sets in. So let's look at the intracranial compliance curve. The pressure and the volume curve has 4 zones. The baseline intracranial volume with the good compensatory reserve and high compliance is the blue part of it. Gradual depletion of compensatory reserve as the intracranial volume increases is the yellow. This is the increasing volume. Poor compensatory reserve, the increased risk of cerebral ischemia and herniation is the red zone. Critically high ICP causing collapse of cerebral microvasculature and disturbed cerebrovascular reactivity is a gray zone. This is intracranial pressure on the y-axis, intracranial volume on the x-axis. The important thing that will come is the glymphatic system. The glymphatic system consists of, can have a look at the diagram. The glymphatic system consists of perivascular spaces through which CSF flows into the brain, which is driven by pulsations of this arterial wall and is facilitated by aquaporin 4 channels on the astrocyte feet. So you can see the aquaporin 4 channel here. Basal lamina, this is the endothelial cell capillary, this is the tight junction, and artery, arteriole, and capillary. The endothelial cells, you can see this is a blood vessel and the penetrating artery. This is surrounded by basal, this is a neuron, and you see all the glymphatic system is kind of perivascular spaces through which CSF flows. You can see the CSF flowing into the brain, driven by pulsations of the arterial wall and facilitated by aquaporin 4 channels on the astrocyte and feet. So the pile arteries in the subarachnoid space are surrounded by CSF sleeve when they enter the brain parenchyma as penetrating arteries. These are surrounded by CSF in perivascular spaces, what we call Virchow-Robin spaces. The arterial pulsations drive CSF into the brain along the perivascular spaces. So the point to note is that the perivascular spaces contain CSF and the arterial wall pulsations drive the CSF into the brain parenchyma. This CSF-filled perivascular space progressively becomes narrow and disappears when penetrating arteries become arterioles and capillaries. The extracellular matrix of the basal lamina then provides a perivascular conduit for continued CSF flow around the arterioles and the capillaries. So aquaporin 4 water channels on astrocyte end feet surrounding the perivascular space facilitate entry of CSF into the brain parenchyma. This CSF mixes with the interstitial fluid in the brain and it's moved by bulk flow to the brain parenchyma to perivenous spaces. Fluid drains from perivenous spaces out of the brain by meningeal and cervical lymphatics along cranial and spinal nerves and possibly through arachnoid granulations. This is the opposite to bulk flow CSF concept, which we have been reading since our MBBS days. So let's switch gears and go to dynamics of ICP and ICP waveforms. The normal ICP is about 10 to 15 millimeters of mercury, as I have already said. More than 15 to 20 millimeters of mercury becomes pathological, and which is critically or catastrophical is more than 40 minutes of mercury of intracranial pressure. Normal ICP trace is pulsatile, and it reflects both cardiac and respiratory cycles. The respiratory wave reflects changes in interthoracic pressure with respiration. The amplitude of this wave I'm going to show you is 2 to 10 millimeters of mercury. This variation disappears as the ICP raises. The pulse component of normal ICP trace correlates with the arterial pressure waveform occurring with each cardiac cycle. The amplitude is 1 to 4 millimeters of mercury. So with the cardiac cycle has got an effect on the arterial wall of the arteries that are present inside the brain parenchyma. Now let us see ICP pressure waves. The wave 1, cardiac cycle, respiratory cycle. You can see this. This is the cardiac cycle, and this is the respiratory cycle. The ICP waveform is due to systemic arterial cycle. The components these are P1, that is a percussion wave, representation of arterial pulsation. P2 is the tidal wave, which is a proxy for intracranial compliance. And P3 is a dichrotic wave, a pressure transmission of the aortic valve closure. So in case of raised ICP and reduced intracranial compliance, you can see the normal intracranial physiological forms change in a different morphology you are seeing, which you can see on the monitors. So intracranial pressure waves of raised ICP, you can see the normal the normal waveform is P1, which exceeds P2, which exceeds P3. You can see the P3, P2, P1. This is the normal waveform. The impaired intracranial compliance and raised ICP, you can see the P2 which exceeds P1, and the critically low compliance P1 and P2 merge. So this is a critically low compliance. So intracranial pressure waves have got a normal P1, P2 and P3. Okay. Now let's look at the Lundberg waves. And ICP waveforms yield valuable information about cerebral perfusion pressure, the regulation of cerebral blood flow and volume also, and CSF absorption capacity, brain compensated reserve, etc. So they all would be. So brain compensated reserves, etc. Lundberg waves are three types, which I'm going to discuss soon. ICP increases when intracranial compliance is decreased and the pathological Lundberg waves A and B appear. A and B, then they start appearing in the monitor. So you can see, actually, when the Lundberg waves appear, there's a right time to administer the mannitol or osmotic agents. So you have C waves, you have B waves, and you have A wave. These are the three types which we're going to discuss slowly. And in the coming slides, I will explain what are all these waves. So the time is given on the x-axis and the pressure is given on the y-axis. The C waves are representing a normal pressure, B waves increased, and A wave is a catastrophic pressure. The C waves may be seen in normal physiology and are related to cardiac and respiratory cycles. So the important concept that has emerged is imagine that CSF, which is surrounding the brain and the spinal cord, is in a closed compartment. There are vessels which are traversing this compartment, and each vessel responds to cardiac cycle. Cardiac cycle is 0.8 seconds, and 0.3 is systole, and 0.5 is. So whenever systole happens, the arteries they constrict, and whenever diastole happens, the arteries they dilate. So these pulsations are transmitted to CSF. So C waves may be seen in normal physiology and are likely related to cardiac and respiratory cycles. Similarly, intrathoracic pressure raises and falls with respiration. So that also will give rise to changes, which I showed you V1 and V2 waves in the earlier graphs. The B waves of Lundberg B wave is due to impaired cerebral compliance and indicate impaired cerebral perfusion and raised intracranial pressure. It is more than almost 20 millimeters of mercury to 30 millimeters of mercury. They occur as 0.5 to 2 waves per minute. You can see the timing which is given on the x-axis will tell you that they have 0.5 to 2 per minute. Now let's come to A waves. So what are the A waves? So we have seen C waves. Now we are going to see A waves. The Lundberg A wave, also known as plateau waves, or you can see the plateau that's coming here, are rapid increases in ICP to 50 to 80 minutes of mercury that typically last 5 to 20 minutes. And A waves reflect critically exhausted intracranial compliance. So the knowledge of Lundberg A, B, and C is important when we are monitoring ICP in ICU. And you can see the ICP on the y-axis here. You can see the intracranial volume on the x-axis. You can see normal, the ICP waveforms, that is at the lower pressure, that is P1, P2, and P3. And as the non-compliance or the compliance is decreased, the high intracranial volume, that mass value more than 30 centimeters, you can see the morphology of the wave that has changed, and the P2 has become peaked here. Now, Monroe-Kellie Doctrine, the brain roughly 80%, blood 20%, CSF 8%, 1600 ml is a rough intracranial volume. The brain tissue includes neurons, glia, extracellular fluid, and cerebral microvasculature. The venous and arterial blood represents the intracranial blood volume in macrovasculature and also cerebral venous sinuses. And CSF includes ventricular and also cisternal CSF. The cranial vault, the vertebral body, and the inelastic dura form a rigid container. In this fixed, non-expansile, non-contractible, and freely communicating space, the pressure of the fluid contents is everywhere equal and directly proportional to the fluid volume. An increase in any of its contents, the brain, blood, or CSF, will increase the intracranial pressure. The pressure-volume relationship between ICP, volume of CSF, blood, and brain tissue, and cerebral perfusion pressure is known as the Monroe-Kellie Doctrine or hypothesis. This hypothesis states that the cranial compartment is incompressible. The volume inside the cranium is a fixed volume. The cranium and its constituent, the blood, CSF, and brain tissue, they create a state of volume equilibrium, such that any increase in volume of one of the cranial constituents must be compensated by a decrease in volume of another. The principal buffers for increased volume include both CSF and to a lesser extent blood volume. So if total intracranial volume stays the same, the intracranial pressure remains the same. Volume of one compartment increases or decreases, the volume of one or both other compartments must decrease or increase for the total volume and therefore ICP to remain the same. If the volume of any compartment is decreased, that of the other two volumes remain the same, the total intracranial pressure must go down. So this model is the conceptual basis for current physiological intracranial pressure management strategies and protocols. It's very, very important. Let's look at the cerebral edema part of it. Cerebral edema denotes an increase in brain water content that leads to brain volume expansion. It can be a focal cerebral edema or it can be a diffuse cerebral edema. It is seen after primary injury to the brain or secondary to a variety of systemic medical conditions. It is responsible for secondary brain injury due to compression, distortion, and herniation of brain structures. Cerebral edema basically increases intracranial pressure and compromises the cerebral blood flow. And there are three types, that is vasogenic cerebral edema, the cytotoxic cerebral edema, hydrocephalus, and interstitial. Let us look at the cytotoxic edema, which is seen in stroke. It results from energetic failure, that is sodium potassium pump failure, and there is influx of osmolytes and cell swelling, what we call cloudy swelling, and also release of vascular endothelial growth factors. On the other hand, the vasogenic edema is due to permeability of blood-brain barrier, allowing extravasation of water and plasma proteins in the brain, and they mediate late onset vasogenic edema in stroke cases. So you can see the vasogenic edema. Lot of vasogenic edema. So the hypercarbic acidosis, and you see that whenever there is hypercarbia, patients are obtunded. Perivascular extracellular pH decreases when there is hypercarbia, and that really leads to cerebral vasodilatation. If the partial pressure of carbon dioxide is more than 80 mg of mercury, there is increased cerebral blood flow up to 6 times baseline, and that leads to hyperemia, increased vascular permeability. And so the ionic edema, vasogenic edema, hemorrhagic conversion, all these things can happen in that. So it's the one what happens hypercarbia. Hyponatremia and lamotrigine toxicity, they always look alike. Hypoxemia makes matters worse whenever there is hyponatremia. So you can see the hypertonicity, extrusion of electrolytes, and cell volume is maintained normally. Hypertonicity, extrusion of electrolytes, and cell volume remains increased in hypoxia. So hypoxia complicates the matters when in presence of hyponatremia, and same pathophysiology is there for lamotrigine toxicity also. There will be obtundation and adverse reactions or increased cerebral edema. Press is another form. Cytotoxic edema can follow the vasogenic edema in press. The press is seen in the posterior part, parieto-occipital region, basically where the autonomic nervous system features are present. Anteriorly, this autonomic nervous system is less represented. So, in ischemic stroke, the earlier first thing that happens is cytotoxic edema. Steroids have no role in cytotoxic edemas. That's why we don't give in steroids. Vasogenic edema can happen later. In ICH also, vasogenic edema happens later. So there are some studies that are coming up with steroids in ICH. And this is the interstitial hemorrhage. Let's look at the various etiological factors and clinical features of raised ICP. In cerebral or extracerebral mass lesions, brain tumors, hemorrhage, and abscess, extraaxial tumors, subarachnoid hemorrhage. There may be anoxic injury, hepatic failure, hypertensive encephalopathy, hypercarbia, Raised syndrome. They all cause hyperperfusion syndromes or global edemas, increase in venous pressure, CVST, heart failure, or prototype examples, meningitis and meningeal metastasis. Okay.
Yeah, Dr. Gorthi, I am not listening you. Sound is not coming.
Yeah. So let's go back and okay, one second. We are looking at the clinical symptoms of raised ICP. Headache is due to pain receptors stimulation of blood vessels and meninges and irritation of sinuses. The vomiting reflex is coordinated by neurons ventrolateral medullary tegmentum near nucleus ambiguous. And the increased ICP produces vomitings by causing pressure on the floor of the fourth ventricle. And the third symptom is visual obscurations and a brief loss of vision on standing. It is due to a dip in the perfusion, due to failure of autoregulation in posterior circulation, occipital lobe ischemia. Other non-specific symptoms are confusion, agitation, air hunger, nasal itch, blurred vision, dysphagia, epistotonus, facial twitching, pallor, sweating, thirst, salivation, yawning, hiccoughing, urinary incontinence, altered sensorium. These are all non-specific symptoms which we cannot give any importance. So, after seeing this, the papillary edema, which is an important finding in raised ICP, there may be false localizing signs of 6th palsy due to its long course and compression when it passes through the osteofibrous duralis canal. When compliance becomes very poor, herniations occur as there is no space of volume to displace. Brain parenchyma itself gets displaced into the neighboring low pressure compartments, which we'll see in coming slides. So let's recapitulate: headache, nausea, vomiting, ocular palsies, altered level of consciousness, papilledema. If it is protracted, papilledema may lead to visual disturbances, optic atrophy, and eventually blindness. But acutely, it won't cause any vision loss unless it is optic neuritis. So the differential diagnosis is optic neuritis and papilledema. The mass effect signs are pupillary dilatation and cranial nerve 6 palsies. The Cushing's triad. Cushing's triad involves an increased systolic blood pressure, a widened pulse pressure, bradycardia. In children, a slow heart rate is especially suggestive of raised ICP. Cheyne-Stokes respiration, which breathing is rapid for a period and then absent for a period, occurs because of injury to the cerebral hemispheres or diencephalon. And hyperventilation, central pontine hyperventilation can occur when the brainstem or tegmentum is damaged. So these are important things. This is the papilledema which you are able to see, advanced papilledema. So let's look at the stages of this thing, intracranial pressure. We'll see in the coming slides. If ICP is 20 minutes of mercury, that is above the normal level, the Glasgow Coma scale approximately is about 13 to 15, drowsiness and confusional states. If ICP is 30 millimeters of mercury, GCS is approximately less than 8 and coma ensues. If brainstem compression is involved, it may lead to decreased respiratory drive and is potentially fatal. This herniation is often referred to as coning. So you can see the volume of expanding mass. We have already mentioned that 30 centimeters square is the volume that the intracranial vault can accommodate. Beyond that, there will be a steep rise in the ICP. If the volume of expanding mass increases, the ICP raises only slightly until the compensatory mechanisms are overcome. This point is reached at the elbow of this curve, which you can see. When the further expansion of the mass causes a steep rise in the ICP. You can see the intracranial volume 1, 2, 3, 4 stages, which we are going to discuss in the next slides. Stage 1, an increase in the lesion volume will be compensated by the downward displacement of CSF and venous blood. These compensatory mechanisms are able to maintain a normal ICP for any change in volume to less than 100 to 120 ml. This minimal increase in ICP due to compensatory mechanisms is known as stage 1 of the intracranial hypertension. Stage 2 is any change in volume greater than 100 to 120 ml would mean a drastic increase in ICP. These characteristics include compromise of neuronal oxygenation and systemic arterial vasoconstriction to increase the mean arterial pressure and cerebral perfusion pressure. One of the main dangers of increased ICP is that it can cause ischemia by decreasing CPP. The stage 3 is a sustained increase in ICP with a dramatic change in ICP with small changes in volume. As the ICP approaches the level of the mean systemic blood pressure, it becomes more and more difficult to squeeze blood into the intracranial space. The body's response to a decrease in CPP is to raise the blood pressure, dilate the blood vessels in the brain. This results in increased cerebral blood volume, which increases ICP, lowering the CPP further and causing a vicious cycle. This results in a widespread reduction in the cerebral blood flow and perfusion, eventually leading to ischemia and brain infarction. You can see the brain herniation refers to the displacement of a portion of the brain from its normal position through openings in the inelastic dura secondary to focal or diffuse intracranial pressure. There will be a focal or diffuse. Focals are seen in strokes, and when we want them to operate, the neurosurgeons will always say, let us wait. But they don't understand this concept of focal and diffuse cerebral edema, which is more damaging. Types of brain herniation: subfalceal herniation, uncal herniation. You can see the uncal herniation, the uncus is going on, subfalceal herniation. Downward central or tentorial central herniation, you can see that's going down, downward herniation. External herniation, that is a D, you can see there is a Suppose if there is a decompression, that then it can be tonsillar herniation. This is the tonsillar, cerebral tonsillar herniation. These are types of herniation that occur, and the same thing is represented here. Subfalcian herniation, the medial shift of cerebral hemispheres, compression of the pericallosal and callosal marginal branches of anterocerebral artery against the forks will lead to infarcts in the ACA territory. These are the secondary recruitment infarcts, they're called. Lateral displacement of diencephalon can be monitored by pineal gland displacement. 0 to 3 mm results in alertness, drowsiness 3 to 5 mm, 6 to 8 mm stupor, 9 to 13 mm coma. The results in decreased alertness. 0 to 3 mm tak decreased alertness, 3 to 5 drowsiness. Uncal herniation is oculomotor nerve is compressed by the herniating uncus, and ipsilateral pupil becomes dilated and may become fixed. So in third cranial nerve palsy with pupillary dilatation is a surgical pupil. Hemiparesis uncus can compress the cerebral peduncle, which is contralaterally placed, and there will be ipsilateral hemiparesis when the contralateral cerebral peduncle is compressed against Kernhorn's notch. Here also secondary recruitment of posterior cerebral artery, which is often compressed in the tentorial notch, and occipital lobe infarction can happen. The central herniation, pressure is due to pressure is on diencephalon. The circle of Willis vessels will get stretched. Ischemia of all around the circle of Willis. Pituitary stalk sharing leads to diabetes insipidus here. The compression on the dorsal aspect of the midbrain, impaired gaze, impaired convergence, refractory, retracted nystagmus. These are other features of Perrinot syndrome, which is seen in central herniations. Tonsillar herniation, a sudden increase in the posterior fossa, which pushes the cerebral tonsils against the foramen magnum, compressing the medulla and causing respiratory depression. Compensatory increase in blood pressure to improve the perfusion. So let us recapitulate the Cushing reflex, arterial hypertension, bradycardia, and respiratory irregularities will happen in tonsillar herniation. So how do we investigate the ICP? There are only 2 or 3 segments more. Non-contrast CT scan is on. It rules out the ICSOL, ICH, hydrocephalus. What are findings that suggest raised ICP on CT? Cerebral edema, midline shift, effacement of basal cisterns, loss of gray white matter differentiation, loss of normal Garay and Salcedo pattern. Now I'll discuss about MRI ICP method and a snapshot of ICP and elastins. It is a snapshot of ICP and elastins. The MRI ICP method is the dynamic MRI. And this is the cardiac gated MRIs have come now. Dynamic MRI measures intracranial elastance, that is inverse of compliance, and how much movement the craniospinal direction the neuroaxis moves. Advances in dynamic MRI enable visualization and quantification of CSF flow dynamics. It utilizes the small fluctuations in intracranial volume and pressure that occur with each beat. So each beat has I'm in the class. Advances in dynamic MRI enables visualization. So as I said earlier, this is a closed cranial vault. Whatever the fluctuations happening in the blood vessel secondary to cardiac cycle, they cause a lot of waves in the CSF, and there is a movement of craniospinal axis in the craniocaudal direction, which will give rise to a lot of pulsations which are captured by the cardiac gated MRI. So that's one aspect which has to be, which you have to read separately and learn. The transcranial Doppler ultrasonography and the elevated ICP impedes the cerebral blood flow and decreases the blood flow velocity. There is a correlation with the mean velocity. There's something called what we call is a pulsatility index. There's a difference between peak systolic and end diastolic velocity, which is divided by mean flow velocity. The transcranial Doppler also helps us in diagnosing this. One interesting thing is a tympanic membrane displacement. Perilymph and CSF, they communicate through the cochlear aqueduct, which you can see the cochlear aqueduct, and this is the CSF. The perilymph and CSF, they communicate through the cochlear aqueduct. An increase in ICP is directly transmitted to the foot plate of the stapes. and this is the endolymphatic duct, and this is the semicircular canals, and the footplate of the stapes can be known. So this communication between the CSF and cochlear aqueduct, then increase in ICP is directly transmitted to the footplate of the stapes. Then there is an inward displacement seen as a negative peak pressure on audiogram. It suggests high ICP, and outward displacement is either normal or low ICP, but the accuracy is very low, 15%. But it's interesting to learn about TMD. There's also another optic nerve sheath diameter. The diameter of the nerve sheath surrounding the optic nerve and the CSF around it can be estimated with the transocular ultrasound. And if diameter is more than 5 millimeters, it suggests ICP of 20 minutes of mercury. It takes about 5 minutes for estimation. So these two things can be introduced in our ICU setups where to learn about this. ICP monitoring, the invasive methods, and the sites are actual and potential spaces, the intracranial cavity in which ICP can be measured. The intraventricular monitoring with EVDs is the most commonly accessed site in clinical practice, which is followed by intraparenchymal probes. But we're not going to talk much about ICP monitoring, but we have already discussed about the waves that are present. What are the indications for ICP monitoring? The Glasgow Coma Scale 3 to 8 after resuscitation, and it should have an abnormal CT scan showing hematoma, contusion, edema, or a compromised basal cisterns, which I talked to you about neuroimaging findings. Then also there is a role for ICP monitoring. Glasgow Coma Scale 3 to 8 with normal CT scan also, ICP monitoring is indicated if any of the two or more of the following is present. That is, age is more than 40, there's a motor posturing, and systolic blood pressure less than 90. Then also ICP monitoring is required. The ICP varies moment to moment. So single pressure recording may miss the fluctuations in intracranial pressure. What is called end hour recording is a good estimate of the ICP for the entire hour. The complications of monitoring or risk of infection less than 1% to 27%. The mean is 9%. Risk of hemorrhage, replacement, and obstruction of catheters happens in 1.2%. So that brings us to the last segment of our talk of management of ICP. See, there are so many things that are there: head position, hyperventilation, osmolar therapy, sedation, analgesia, skeletal muscle paralysis, seizure control, hypothermia, decompressive hemicraniectomy, barbiturates, and steroids. So you can see the cerebral perfusion pressure formula. You have to reduce the cerebral metabolic demand and cerebral autoregulation and coupling of the cerebral blood volume to cerebral metabolism. And you can see this again, I have already explained about the Monroe-Kellie Doctrine, so I'm not going to touch about it. So what are the measures to reduce? If it is a vasogenic edema, you can give dexamethasone 4 milligrams IV 6 hourly with pot floor, shelcal, and ranitidine. You can give mannitol 1 gram kg IV and Lasix, glycerol, hyperventilation, hypertonic saline. We'll discuss the advantages of hypertonic saline and mannitol later. Dilantinization or any other suitable anti-seizure medication, maybe EVD, VP shunt, surgical excision, and in case of malignancies, chemotherapy and radiation to be required. So the head position is very important, and elevation of the head to 30 degrees. There are pressures, these are pressures which are across different body compartments in the body, and you can see of them, the pressures are variable. The important thing is that head should be the midline in cases of stroke. Avoid placing central lines in the internal jugular veins and minimize the positive end expiratory pressure. As you said, the ICP waves are dependent on respiratory cycle also, as well as cardiac cycle. Minimize abdominal pressure. You have to prevent constipations and ileus. So that will also help in. The hyperventilation is a temporary measure. The target is you bring down the CO2 partial to 30 to 35 only. So you can see that hyperventilation and the injured brain, normal brain. So hyperventilation will to some extent help, but it is not going to serve you for long. So immediately if there is a time, 10-15 minutes before it is taken up for surgery, then you can think of hyperventilation. Choosing the right agent is important for sedation and analgesia. Using a validated scale like a RAS scale for validation for agitation and sedation is important. And you have to escalate and de-escalate appropriately. If there is ICP, raised ICP, you can go sedate, analgesia. And then if it is not there, you have to slowly, you have to bring it down. Currently pain, agitation, delirium, and ventricular ventilator asynchrony, all these things should slowly reduce, and you have to finally become no sedation. So clinical examination and brain imaging will help, and you have to remove the analgesia also sometime. Initially it may be there, and there may be dexmedetomidine administration, sedation, they all should go, but they all increase the adverse effects of the ICP. So let us look at the mannitol and hypertonic saline. Hypertonic saline is nothing but salt, right? Mannitol is a naturally occurring sugar alcohol and is an isomer of sorbitol. 20%, 20%, 10%, 25% in 500 cc bags of water containing 50 grams, 100 grams of mannitol, or 25 grams in 100 cc bag of sterile water, respectively. You can get the preparation. And similarly, sodium is 22%, 3%, 7%, 14, 23.4. This you have to make it in the laboratory. What we get is 3% hypertonic saline. You can make 7% also. If you request the blood bank, they should be able to make. The usual dose is 1.5 grams per kg via and inline or 0.2 units of filters if you are using. And here it depends on the concentration. We keep the serum sodium to 145 to 155 approx. So bolus or bolus administration, especially when Lundberg A and B waves are seen, it should be given. Then only it acts better. And here it's a central axis required for the normal hypertonic saline administration. Otherwise, thrombosis happens. Onset of action for mannitol is 10 to 20 minutes. And for saline, it is almost 5 minutes. For if you are using hypertonic, 23.4% saline. So what are side effects of mannitol? Hyponatremia, acute kidney injury, hypokalemia, hypomagnesemia, hypotension, phlebitis, and especially should be careful when there is an end stage renal disease. So in that case, you have to do a frequent VMP, serum osmolality, 6-hourly, police for strict intake output monitoring, and all these things are important when you are going to have mannitol. What are the complications of hypertonic saline, which are adverse effects? Electrolyte imbalances, hypernatremia, hypercholemia, chloremia, hypokalemia. These are which we can keep seeing in our ICU setups. Metabolic acidosis, acute renal failure due to hyperosmolar states, volume overload, flash pulmonary edema, heart failure exacerbations, phlebitis. One important, during rapid administration of hypertonic saline, there may be bradycardia and hypertension. So should be careful on that. Pentobarbital coma is another method which reduces the cerebral metabolic rate of oxygen consumption, CMRO2, and a continuous EEG is required to target burst suppression pattern. Again, the adverse effects, hypotension, bradycardia, and pneumonia, and immunosuppression, hepatotoxicity. The dose is 5 to 10 milligrams per kg given as a bolus dose, and then drip 1 milligram per kg per hour to 5 milligrams per kg per hour. Therapeutic temperature management, TTM, that should not be used as a strategy in lieu of the surgical decompression, but it's a 3-tier strategy. And I'll tell you the tiers of management of ICP. It's used in refractory ICP crisis with close clinical monitoring and anti-shivering protocol. Temperature targeted is 32 to 34 degrees centigrade. So the tiered approach and tier approach of management, and you have this approach for elevated CCP has got 3 tiers: 0, 1, 2, and 3. What happens in 0? The standard measures for all participants at risk of ICP elevation, supportive airway breathing circulation, analgesia for comfort, sedation to tolerate mechanical ventilation, avoid fever, keep the temperature normal, avoid constipation, abdominal distension, head up 30 to 40 degrees elevation, head should be in the midline, avoid jugular vein compression, isotonic hyperosmolar fluids which are targeting normal serum sodium, steroids for vasogenic edema. These are the general principles. One of the things which it's difficult to observe is these two things: the head in midline and avoiding some jugular vein compression. Every critical care specialist is interested in putting veins in that one. The number of times I keep telling, but they go back to same practice. Mannitol or hypertonic saline for symptom directed or osmolarity or sodium level goal. You can use these two things. And CSF diversion and the external ventricular drainage, 5 to 10 ml of external ventricular drain in place. Selective consideration of surgical decompression or lesion resection, mild hyperventilation. Hypertonic saline, if refractory to mannitol, consider higher osmolarity goal. You can increase to 3 to 7 to 23.4. Sedation and analgesia for deeper or RAS scale. Reconsider surgical decompression life-saving measure, mild hyperventilation. The life-saving measure, decompression, which we were discussing today also, is the case 7 days old stroke, which is stroke which is deteriorated, whether that case should be subjected to decompression. There is a role, but not often done. 3, patient stage 3 is determined tier 3, not to be a surgical candidate. Then the temperature management will come into picture. Sedation, barbiturates, and the EEG burst suppression is targeted. Moderate hypothermia, core temperature to 30 to 34 degrees centigrade. So, in summary, we have read, we have understood core physiological principles: Monroe-Kellie Doctrine, intracranial compliance, cerebral perfusion pressure, cerebral blood flow, cerebrovascular resistance, intracranial ICP. We learned about cerebral autoregulation. We studied ICP waves, pathological. We studied coupling of cerebral volume to cerebral metabolism, osmotic gradients and movements of water and cerebral edema. We have gone through all this. Also, the core interventions for raised ICP, stepwise management, the tier management, hyperosmolar therapy, sedation and analgesia, CSF diversion, decompressive hemicraniectomy, and hypothermia. So I think with this, we'll finish. I conclude by saying that diagnosis and management of ICP are cornerstones of neurocritical care. The review of literature showed paucity of high quality studies for most methods of ICP control. A stepwise approach is discussed, but there is a need for high quality RCTs to define the role of different methods for ICP treatment. I think with this, we'll finish. Sinha sir, any questions? Any comments or questions from anybody about ICP? Sir.
Very lovely revision on this topic. And it is very, very important. Now we are getting a lot of stroke patients. And once they start coning, particularly the large hemispheric stroke, and we want to sell this product to surgeon to open up, they do dilly-dallying and we get into problem. We lose the life. So the first thing is the altered sensorium. Is like you say, drowsiness. The moment it comes, or the midline shift 5 millimeter, they must give mannitol, prepare it, and take up for opening up. If they delay it, then we invariably find a negative result. This was one. Mannitol is all temporizing, mannitol, saline, because the basic problem is a structural lesion inside that has to be decompressed. So, and then second was intubation. When the patient is confused and he is having GCS of 8, there is a rapid sequence intubation is recommended. And that time, there is some concern about giving short-acting muscle relaxant. which causes things. Somebody suggests that dextromethorphan is a better option than that. Anyway, I don't know. What do you do in your setup?
They use dextromethorphan, and they use all types of sedation. Sedation is actually biggest bugbear in ICU. We don't know how much sedation to give, how long it should be given. Sedated patients usually go into aspiration pneumonias and other complications. And a neurologist can't do if the patient is sedated. By the time we reach,
because that's a
he's
anesthetic
intubated,
domain.
he's sedated, pupils are constricted. Nothing you can assess in the sedated patient. Nowadays, it's become a standard practice to sedate deeply and put the patient to the rest.
Absolutely. If patient struggle at that time, then it raises the intracranial tension.
Yeah.
Absolutely.
So sedation is used effectively at the beginning, but how long to continue is a debatable issue. And
They
how
put on,
soon they
after sedation, they have to hyperventilate immediately first, so that the PCO2 is around 35 or less, and then take off for surgery, basically, these cases. So these are the first 1-2 hours before they are wheeled into surgery.
Yeah.
Second thing was a very interesting point you brought out about lamotrigine. Tell me about that.
Oh, lamotrigine also has a toxicity, and it's just like hyponatremia complicates the hypoxia and causes more confusional state and encephalopathy. Lamotrigine also has the same effect. And
so
it
in which
causes
setting they have
swelling.
recorded this?
It causes encephalopathies.
Okay.
Obtunded sensory. So lamotrigine as such has got a lot of side effects, including the toxic epidermal necrolysis and things like that. So though it's a good drug, one has to be careful.
In fact, what has happened, it is economical drug. And once we are replacing all the old generation medicine, in fact, I find dilatin is still good enough to most of the patient.
Yeah.
And phenobarb.
I agree
but
with
the
you,
first line treatment now has become Keppra.
But that drug is a very, very complicated drug. Many people have adverse reactions which are not recognized, the behavioral problems, the fights they have, and these things came into vogue subsequently under observation. And now it has become a fad. Everybody remembers only one drug, that is levetiracetam. Everybody uses that.
Including for a status now giving for the IV thing, as they have approved it now.
So they use only that drug. That's a very, very sad thing, but we can't help people. They actually, first line drugs are very good. Sodium valproate, carbamazepine, phenytoin, and phenobarb. They have been there a century old almost. One of them. They are much better than the recent drugs.
Anyway, once again, I compliment you for doing such a lovely slides. You have put in so much of labor in it. Hats off to you. Thank you very much.
Thank you, sir. Any other students want to ask any questions? You can unmute and ask. Anybody wants to ask anything? If there are no questions, good night, sir. Good night, everybody. Thank you very much. Let's stop here.
Thank you very much.
Good night, sir.
Good night.
Bye.
Okay.